He also was conferred the fellow, honorary fellow in allergy and clinical neurology by Savita University, and he's the only first and second pediatrician, only one of two certified pediatric allergists, and by EACI, pediatric allergy and clinical immunology from India. Much of his work was dedicated to not only training students and teaching students, but also was dedicated towards IAP and Indian Academy of Pediatrics, and for the growth and development of Indian Academy of Pediatrics. He started from as a grassroots worker from IAP Kanchipuram and IAP Chennai City branch. Then eventually founded the IAP Kanchipuram branch in 2000 and worked as an honorary president in IAP Kanchipuram, treasurer for IAP Tamil Nadu State, secretary, executive board member for IAP Infectious Disease chapter in 2018, 2008. Vice President for IAP Tamil Nadu State Branch in 2008, and successfully launched the IAP Allergy and Immunology Chapter Founder Secretary in 2009. This is a great, it took a lot of effort and a lot of convincing, a lot of work went into, mobilizing people in creating the first chapter in allergy and clinical immunology in India, especially in IAP chapter. And he was also the president of IAP Tamil Nadu State Chapter in 2016, National Executive Board member of Central IAP, and he was the IAP South Zone Vice President in 2020 and 2021. Apart from this, he also held multiple positions as a council member, joint secretary, and vice president of the Indian College of Allergy, Asthma, and Clinical Immunology. He has organized multiple numerous workshops and conferences in pediatrics and all over the country, well known for his posters and paper presentations in national and international journals and publications and presentations in international forums, and authored chapters in various textbooks in pediatrics, but very famous for his manual of pediatric allergy, which has come up with the second edition in 2020. He has sponsored 2 gold medals in Sri Ramachandra Medical College and Sri Balaji Medical College for the best outgoing students in pediatrics. He also was the editorial member for latest national and international pediatric journals. This is a picture where he is shown with the 3 doyens of pediatric allergy, Professor H. Parameshwar, Professor T. Sukumaran sir, and Prof.Major.K.Nagaraju, who shared and who were responsible for creating the field of pediatric allergy in India. Multiple modules were also developed, and he was innovative in his ideas in creating more interesting and innovative ways of treating or putting out the message of teaching allergy, and was responsible for creating the first module, which is ADEX module, and for the ARCTM module. The ARCTM module was the allergic rhinitis comorbidities training module, and also for CARE module, which is the childhood allergic rhinitis expertise, and CAGE module, which is childhood allergic diseases education modules. This is his center, which is VN Allergy Center, which is Birth Child, which is inaugurated initially as a pediatric and gynecologic hospital in 1995, and then successfully changed into a complete allergy center in 2004. Since then, we've been working, the entire center is dedicated to the diagnosis and treatment of patients with allergic diseases, and also for culminating research and propagating research activities across the country. And he's all well known in most conferences. He was the most sought after speaker. For most, you can see here in this picture that after every speech or every talk, that there were all the doctors used to converge around him and try to solve their doubts with him and learn from him. And that he also had. This is the first batch of fellowship in allergy and clinical immunology. The first 8 students which passed out. Dhanesh Volvoikar sir is part of this group, and subsequently the 3rd, 4th batch also, and we had conducted the workshop in allergy and specific immunotherapy. For the first workshop was conducted between 22nd and 24th January 2020 at VN Allergy Center. And this is the first batch of students who passed out from the workshop of allergy and immunotherapy from our center. And the first Prof.Major.K.Nagaraju Oration was conducted during the time of COVID with Professor Suresh, who was kind enough to join us at the time in 2020. And this was the first Major.K.Nagaraju Oration. And this was on the topic beyond COVID-19 and what is waiting for COVID-19 warriors, which is well appreciated and well received all over the country and internationally also. The second Professor Major.K.Nagaraju Memorial Oration took place here on 27th November 2021, where the keynote speaker was Professor Nicholas Papadopoulos from Greece. And the chairpersons were Dr. T. Sukumaran and Dr. Sridhar Ganapati. And this is the second edition of the Manual of Pediatric Allergy. We owe a lot to this because it has simplified everything that we need to know in allergy, especially with pediatric practice. And this is considered as one of the must-read textbooks in current practice in pediatric allergy. Thank you. So I take great pride and consider it my honor to introduce the speaker for today, Professor Dr. Sellappan. Sir has joined us from Penang, Malaysia. In brief, he has completed his MBBS from the University of Mysore, where he has won multiple gold medals. He was the best outgoing student in multiple subjects. He has completed his PCH from London, FRC PCH in the UK, and MRCP from Ireland. MRCP, and following MRCP, he did his diploma in allergy from the prestigious Tyson St. Thomas Hospital, UK. He's currently working as a consultant pediatrician and allergy specialist at Volvoikar Hospital in Penang, Malaysia. He's associated as a clinical professor at the Asian Institute of Medical Science and Technology, Malaysia. And so he is well known for his work in the field of allergy in the last few decades, where much work has been, and we will be discussing about this on the natural stabilized extracts as treatment for atopic dermatitis. So I welcome you and thank you so much for taking this opportunity to be with us.
Thank you for the kind introduction, and thanks and appreciation for giving the opportunity to address this august organization. My association with Prof. Nagaraj goes back many, many years when he first delivered a lecture in Penang, and he was introduced to me by Professor Tamin Ansari from Chennai, who was in Penang at that time. And since then, we have been working closely on allergic disorders, and I've actually sent a few patients to Prof. Nagaraj in the past. Some of them had some severe allergies that needed some special expertise. So he was an excellent clinician and a very good friend. And so sad that he is no more, but I cherish all the fond memories that I've had with him. And I'm happy to see his son and daughter-in-law carrying on his good work. And I'm sure that he'll be proud of them. Okay, let me start. I will talk. I've done some work on atopic dermatitis. I'll let you know about some of the work that I've done in atopic dermatitis and urticaria here in Penang. So as we all know that the allergy is increasing rapidly now, and as we all aware that there are two theories for that. One is the pollution hypothesis, where with increased pollution goes hand in hand with increased allergy. And the other is hygiene hypothesis. All of us are very clean now. The children are extremely clean. We drink RO water, filtered water, we use air purifiers. So we are not exposed to the normal pathogens and allergens, and the children are not exposed to it now as what we were exposed to in the past. So that is another reason why the allergy is increasing. There's a quick word about skin prick test. I had actually delivered, when I started doing skin prick tests in 1998. And the year 2000, I had actually delivered a lecture in Chennai to the Indian College of Allergy and Immunology on skin prick tests. Currently, to date, we've done about 6,000 over cases in our hospital. And I tend to do the skin prick test more for allergic rhinitis asthma, and I tend to use blood tests more for atopic dermatitis. But for allergic rhinitis asthma, among all the patients, actually those who are positive, or 55% were positive, had allergy to house dust mites. And of course, the other mites also. Just a quick word on atopic dermatitis. It's very common. It affects in Malaysia, it's about 20% of the infants affected. And the principles of treatment, as we all know, it's moisturize. And of course, then we use other medications as and when necessary. And family advice and counseling is extremely important. So when I see patients in my clinic, I tend to use the online patient-oriented scoring for atopic dermatitis. It's a SCORAT calculator. It's actually very easy to use. We look at symptoms, intensity, and the extent of the body surface area that's affected. Although there are another two assessment methods available, I tend to use the SCORAD calculator. And actually patients can use it themselves. It's actually very much patient friendly, and it's also very doctor friendly. It's extremely easy to use. There is a calculator, there's a formula for calculation, but all will be done by the computers. We don't have to do the calculation ourselves. There are three things we look at: the extent of the disease, the intensity of the disease, and the subjective symptoms. So when we look at the possible symptoms, of course, there are several symptoms in eczema: erythema, edema, swelling, oozing, excoriation, like implication. And so the first part is you map out the body surface area, and then the intensity of the symptoms, and the the signs and intensity of the symptoms. These are the three. So the symptoms is pruritus and loss of sleep. So 0 is if there's no pruritus and there's no loss of sleep, and 10 is the maximum. So then we just have to key into the system. These are the different parameters. So you just click on the different. It will be like this. There'll be circles where you just tick, and when you finish, then you get the total scoring. Okay. So it started with initially it was doctor had to do it manually. Then subsequently it was computerized. Everything was on computers. Now you have the latest version, which is actually a big version, so much more data. So when when you have a score, the score previously ranging up to 84. With the new one, the score is ranging up to 103. So anything below 20 is mild. 20 to 40 is moderate, and this is for SCORAD. Bottom is ERC. So when you go for SCORAD, the up to 40 is moderate, and beyond 40 is severe. We have a lot of issues in atopic dermatitis. The first thing is what is the cleanser that the child should use? Because patients come and tell me, doctor, I've used this cleanser, it's not working. I've used that, it's not working. What should I use? So I was actually looking for, there are several cleansers available, soap-free cleansers, which minimum chemicals, but as you all know, all the liquid cleansers have alcohol. And that's a preservative. So without alcohol, they cannot make a liquid cleanser. And so this itself irritates the skin of quite a few patients. So even the mildest cleanser can irritate the skin of patients. So I was actually looking for something that was safe and effective. So then there was a gentleman from India, from Chennai. He, with some local people here, developed technology to stabilize rice bran. Okay, what I'll do is we just go. Okay, rice bran. Rice bran is a byproduct of rice milling. So when the rice comes from the paddy comes from the mill, you have the husk. After that, you have a brown layer, that is the bran layer, and then you have the white layer. So once they remove the husk, the bran gets infected because there's high oil content, gets infected with the bacteria, rancified very quickly. So as soon as the husk is removed, the bran also portion of the rice particle also has to be removed. Then you get the white rice that we eat. And as you all know, white rice is full of carbohydrate. The bran, that's a brown powder, is the one that's highly nutritious. Okay. And but unfortunately, since it gets infected with the bacteria, all over the world is either used as animal feed or thrown away as waste. Or cattle feed, poultry feed is all rice bran because it's highly nutritious. So these people have they developed a technology to stabilize rice bran without any additives. And I was approached to see whether I could help them in doing some medical research on the rice bran. Okay, rice bran, as we know, is it reduces blood sugar, and then it can reduce cholesterol, high blood pressure, obesity. And there is some in WebMD, there is some mention that rice bran can help in eczema. There has been one study that I've seen that rice bran bath was rice bran bath was used for one study. That's only one study I could find on that. The rice bran broth bath was used for atopic dermatitis with positive results. Okay, so what I as a pediatrician, of course, I told them I'm not able to perform studies on cholesterol and diabetes. So I agreed to, I looked at the matter and found that since it is effective for atopic, it's potentially effective for atopic dermatitis. I said we will conduct a trial using that for patient atopic dermatitis. So the benefits is it is actually useful for dry skin, for combination of dry and oily skin. It has anti-aging properties. It has it's also effective for acne-prone skin and also for sensitive skin. Okay, and but there are some concerns with the rice bran that since it has a protein element, that it can cause some redness, itchiness, sometimes can make the acne worse, dullness and dries out the skin. That is a potential worry. Although supposed to moisturize the skin, it could theoretically cause some dryness. So rice bran has a lot of ingredients, as you can see on the slide. So the technology was, there's no additives, it's pure rice bran. They stabilize it using heat, but while preserving the nutrients. And when we did the studies on that, we got a shelf life of about 2 years, and the pH was 5.9 to 6.5, which is suitable for skin cleansers. Okay. And then, so there's the so just to it's supposed to help in skin moisturizing, regeneration of damaged skin, skin brightening, whitening, and anti-aging. So it has a lot of micronutrients and antioxidants, namely gamma oryzanol. There's a lot of vitamin E. I won't go through the details of it, but generally it's supposed to have some anti-sunblock effect, regeneration, and moisturizing effect. Then omega-6 fatty acids for moisturizing the skin, high dose of vitamin B. So it helps moisturize the skin, promotes skin microcirculation, slows look of anti-aging, brightens the skin, evens out skin tone, minimizes appearance of dark circles, and increases skin natural regeneration and soothes irritation. This is what I got off the internet during from various sites. Okay. But nobody's actually done a study using this on the skin because it's just been very difficult to stabilize whole rice bran. There are 1 or 2 companies that have been that are producing rice bran, but they split into soluble and insoluble components and sell different components. So this is full rice bran as such. So what I did was we use it as a cleanser and as a emollient. So as a cleanser, the patient would, it's just a powder form, okay? It's just a rice bran powder. The patient would wet the skin and then would apply the powder to the body, leave it for 5 minutes and rinse it off. So the advice given was that they use it as a cleanser once a day, maximum twice a day, but not more than 2 times a day. Not to have a shower more than 2 times a day. Okay. And as an emollient, the advice was that they take a bit of powder, mix it in water, make it a paste form and apply it to the affected areas, leave it overnight and rinse off the next morning. This and so the study we conducted was over 6-week period. We had about 50 patients ranging from 42 days up to 18 years. The mean age was of the patient was 4 years. So the patients were seen at day 1 and then 2 weeks, 4 weeks, and 6 weeks apart. So they were assessed clinically, and so they had the clinical observation questionnaire, And objectively, we use the SCORAD calculator. So when we started the study, we had a baseline of the SCORAD value of about. I did it only. So we concentrated mainly on children who were mild to moderate. We had a mean value of 26. At the end of study, the mean SCORAD value dropped from 26 to 11. Okay. So this was out of 50 subjects, 2 dropped off from the study because they moved away from Penang at that time, and 48 completed the study. So I did find that it was effective. So I'm at the moment in the process of writing up this paper for publication, but based on this, as okay, I'll just show you about 3 patients who had very significant improvement. There was a 9-month-old boy who had a score of 37 initially to start off with, and at day 28, 4 weeks, the skin was much better. So all these children, what we did was they used this as a cleanser and as a moisturizer. But if they were on their own antihistamines, they would continue that. But they were not to use steroid, any steroid, whether it's topical or oral. That was the condition of the study. But they could still take antihistamines. Okay. So this boy, as you can see, the skin had improved after about 4 weeks. This boy had the best improvement. He is a 13-year-old boy who had a score of 80. He had been suffering from eczema right from infancy and had all these ulcerative tract relations. But I was quite surprised. Over a period of 42 days, the skin had come back to almost normal. He still had dry skin. He still has dry skin, but it is so much better. And he said for the first time in life, he was actually ulcer-free. And then we had another boy who is, this was a 42 days old baby. He started with a score of 50, and then it dropped to 29 after 28 days. So this boy was on breastfeeding and formula feeding. So once when we started the study, managed to convince the mother to stop the formula milk and go for full breastfeeding. So he did improve. So probably that could be one of the reasons that fully breastfeeding, but there was definitely very good improvement over a 4-week period. So based on this, as everyone knows, that the gold standard for medical research is actually a double-blind placebo-controlled study. So we are going to go on for a new study, which where with the active arm, we will be using stabilized rice bran, and for the placebo arm, we'll use cornstarch. Cornstarch also has some antioxidant activity, but I couldn't find any other placebo that is totally inert on the skin. So we are going to, for that, we are having 3 parameters that we have decided on. Dr. Karthik and Dr. Kash will be joining me in the study. We have one is the SCORAD score, and then in association with Prof. Elizabeth Ryan of the Colorado State University, she has done a lot of studies on rice bran, giving it orally for various conditions. We have come up with a patient compliance intervention questionnaire, and we will be looking at transepidermal water loss. Okay, I'll mention that in a minute. Also, I'm looking for proper equipment for statum corneum hydration assessment and skin pH. If I'm able to find that equipment, I will add it in. But I've already sourced this transepidermal water loss equipment. And of course, that will have ethics approval too, as before. So as we know that the skin barrier is usually intact. But in eczema, so we have the statum corneum, we have the epidermis and the dermis. With eczema and with or any condition where there's a break in the skin barrier, we have two issues. One is as excessive water loss, and one, there is external irritants can go into the body and cause damage. Okay. And in how do we measure the insensitive water loss? Insensitive water loss is by two means. One is through the skin and one is through the lung. Of course, then the water loss that we can measure is the urine water loss. So the average water that's in an adult loses about 300 to 400 ml of water per day through the skin, and an equal amount is lost through the respiratory tract. And this accounts for about 30 to 50% of the entire water loss from the body. Okay. So if in eczema, because there is a break in the skin barrier, there is definitely much more water loss. Okay. So if we are able to measure the water loss, we can actually scientifically quantitate whether it's getting a condition is getting worse or getting better. Because if the water loss is improving, if less, then the condition is getting better. If after treatment, if the water loss is worse, then the condition is more than the condition is getting worse. Okay. So transepidermal water loss is considered one of the most important parameters of skin barrier function. As you know, as we age, our our skin cannot hold moisture effectively as the younger adults and children are able to. So the skin's metabolism starts slowing down when the skin metabolism slows down. By about after 40s, 50 years, the skin definitely becomes noticeably drier and more flaky. Okay, and sun damage also causes problems to the skin. And with drop in estrogen levels at menopause, the skin gets in ladies gets much thinner and less elastic. And also at the same time, sebaceous glands produce less oil. So the ultimate effect is the skin barrier function becomes much weak. Okay, and so there are a lot of things that can actually damage the skin in addition to injury and not, like, you know, if a person has burns, also they lose a lot of water. So any damage to skin, the barrier, you will have loss of water. Same thing again. So this is the transepidermal water loss equipment. Okay, there are three medically validated equipments in the market. You have one is an open chamber and one is a closed chamber. So the open chamber is the more dominant one in the market. But there's some issues with that because it's open to the environment. So what you need to do is, its humidity will affect the results. So you have to do it in the same humid condition at all times and at the same spot of the body. So you can't do it outside the house one day in the open air and one day inside the clinic. It has to be a controlled environment, but it's the reading in the controlled environment is very good. The other one is a closed chamber, which is actually faster and much easier to use. It can be used outside or inside your clinic. You can go even out in the environment, in the open sun, you can use it because the environmental temperature and the humidity does not affect this particular meter. But unfortunately, if the child is having excessive water loss, the chamber can get saturated and you will not get proper results. So they have the pros and cons. There are 3 meters in the market. One is called PO meter, that's open chamber, vapor meter, and Aquaflex. Aquaflex by far is the best, but it's also the most expensive, extremely expensive. Okay, that's with my experience with atopic dermatitis. I just quickly talk on other treatment that have recently started for very severe atopic dermatitis. Dupilumab, monoclonal antibody, a biological product. It can be used from 6 months up to 18 years. I've started for 2 adult patients. The loading dose normally for adults about 600 milligrams, and then you give 300 milligrams every 2 weeks. And so with the different ages, the dose dose varies. So I've started for 2 patients. One is 32 years old and one is 45 years, where each the first one has scored a score of 83 and the other one 81, 83. There is some improvement definitely at the end of 4 weeks now. I started about a month ago. The end of 4 weeks, there is improvement with that. So I'm quite happy. But some of my friends in the US, allergologists, they've been using it for quite a few years and they're quite happy with this particular product. And the only problem with this is really expensive. Okay. I've not taken any photo of those patients, but I've just taken some stock photos to show that there will be there's improvement after taking both in the hair regrowth and on the body improvement of the rashes. See, so they say that once before starting and after starting, it's supposed to be much better. I would just like to finish off with chronic urticaria that so as urticaria, it's a very common problem that we see in our practice. As we all know, there's present urticaria on most days for a period of 6 weeks or more. But the only good thing is about 50% will recover in a year or so, in 1 year. Okay. One of the I'm not going to go to the laboratory investigations because our next speaker will be talking on that. The one investigation that I do for this chronic idiopathic urticaria is I do this autologous allergy testing, where we draw the patient's blood, spin it down, take the serum, and we inject it into the volar surface of the forearm. Okay, is to test for chronic autoimmune urticaria in patients with chronic spontaneous urticaria. But you can get some positive results in autoimmune thyroid disease and Helicobacter pylori infection. So what we do is that we need 3 specimens. One is the patient serum, the other one is normal saline, and the other third is histamine. So you need a positive control and a negative control. So this is injected into the volar surface. 0.05 ml is injected in the volar surface, and you see for the response after 30 minutes. Okay. So you have the 3. I tried doing a skin prick test on this, but I did not find the effect was very good. So for this chronic urticaria, I tend to do this particular test. Okay. And so if the response is equal to or larger than the histamine response, then the there is autologous disease. Okay. And the treatment of urticaria as a first-line treatment, we use only antihistamines. Second-line treatment, we go to second-generation antihistamines with a very high dose. For adult patients with cetirizine or loratadine, I go to a maximum of 40 milligrams per day. Okay. The normal recommended dose is 10 or 20, so I go to 40 milligrams. According to the European Council of Allergy, they say you can go up to 90 milligrams a day. Okay. Third line that I use is omalizumab, which I think this is also available in India. It's recommended for chronic idiopathic urticaria and uncontrolled asthma. So urticaria is for above 12 years and asthma is for above 9 years. For the adult dose, there's some meta-analysis of 67 published reports showed that it was effective, where we use the urticaria score, urticaria activity score. Okay. The dosing is 300 milligrams subcutaneous every 4 weeks for 6 months. I tend to give it in emergency and A&E department, just to cover the risk of in case the person has an anaphylactic reaction. Okay, so what we monitor with the urticaria activity score over 7 days, UAS 7, which has that's the number of wheels, plus where you get 0 is there's no wheels, and 3 is more than 50 pruritus score, and that gives you a total score. Okay. Same thing. It says study showed that it's effective. There are some side effects reported in the literature, but so far I've not come across any problems. Any of the patients are given this too, but anaphylaxis and malignancy is the side effects that the patients are worried about, because all our patients are well educated, and they go and read up before they take the medicine, and they come and tell me, am I going to get cancer after this, or am I going to get anaphylaxis? So to cover the risk of anaphylaxis, I give it in A&E department. But of course, I try to reassure them that the cancer risk is just minimum above the placebo risk of getting cancer with placebos. Okay, I've so far used it for 18 patients. 14 of them finished the course, and they had dramatic improvement after the second to third injection. 4 patients actually discontinued the treatment because of the cost factor. Okay. So second, third injection, patients were much better, and they were able to go off all antihistamines. Okay. Thank you.
Thank you so much, Dr. Sellappan, sir. It was really a very, very new concept that all of us have been introduced to. We thank you from the bottom of your heart to have accepted this invitation and enlightening us with the very new concept in atopic dermatitis. All we have been hearing in atopic dermatitis is we'll have to live with it throughout the life, and emollients are the go-to medicine. But this was a really, really nice concept. So thank you so much, sir. With your permission, we have a few questions if we can take.
Yes.
Question is, can topical application of rice increase the allergy?
Yes, there is like I said earlier on, the rice bran actually has protein, and in theory, any protein can cause allergic reactions. So what we did this was before the patient started using it, what they did was they would mix it into a paste form and apply it to the skin, leave it for 2 hours to see whether any reaction. And there's no reaction, only then they would proceed to use the rice bran. So in theory, yes, it can cause allergies, but in practice, in the 48 patients or even the 50 patients that we use it for, I did not come across any allergies. So my next study would be much bigger, and hopefully I'll have more information after that. But to date, I've not, in theory, yes, but in practice, I've not seen any allergies. In fact, it's very safe. If it falls in the eye, you just wash it off. If the child were to by mistake swallow it, nothing will happen, because it's food grade. It's a food grade cleanser. It's totally edible.
All right. Thank you, sir. We have another question. There's a doctor who's asking if there are any trials of rice bran as an emollient in non-tropical, non-rice growing areas.
There's been no studies on rice bran so far on the skin. All studies have been for cholesterol and other cholesterol, diabetes, all that. So this is, to my knowledge, the first study. I did a Cochrane search. I couldn't find any study on rice bran on the skin. So so this will be the first one. I'm still looking to see whether any other studies, but to my knowledge, no, there'll be no other studies.
Sir, again, whenever we introduce a new concept, the first question that comes to mind is we need the contact number. We need the, how to go about, how to further proceed with the new concept. So we have a couple of questions on how can we procure, how can we start using this new concept in atopic dermatitis. I
think this is, the company is still in the research mode. They have not commercialized it yet. So they want to be 100% sure before they commercialize it. And I will keep you informed, because once the next study is done, then I think we should have more information. I could put you in contact with I could pass the person's details to you, the company's details. That's not an issue.
Sir, again, this is a very small request from a couple of participants who have joined. If you can enlighten us within a line or two regarding how we use the rice bran for treating atopic dermatitis. We have a couple of questions wherein they could not place the physiology of how it works actually. So just a gist of your slide.
Okay. Rice bran has a lot of it has a high content of antioxidants, micronutrients, vitamins, minerals, and oil. There's very high content of oil. Rice bran oil, per se, and so all these put together, you have tocopherol, tocotrienol, gamma oryzanol, and a lot of other vitamins. So totally all this put together has two effects on the brain, on the skin. It moisturizes and regenerates damaged skin. So far, all our what we have had is the cleansers that we have only moisturize the skin. They do not regenerate the skin. Regeneration of the skin comes from medications. So this, in theory, is supposed to have both the effects. It moisturizes and it regenerates. So the oil moisturizes and all the other antioxidants regenerate the skin. So, and it also has sunblock activity. Okay. I'm not sure exactly. That is our next thing. I need to look at what is this, sunblock factor, what is the value that this has, but it definitely has some sunblock activity, and it brightens the skin, and it's supposed to whiten the skin. So, eczema, sometimes the skin becomes hyperpigmented, it's dark, so it's supposed to whiten. All this is theory. It's supposed to whiten and has anti-aging activity because it regenerates damaged skin. So that is that's theory. In practice, I see some of the effects in the patients that we have used it for, but of course, I need to compare it with the placebo to be 100% certain.
All right. Thank you, sir. Again, we have a question from Dr. Milan Modi, who wants to know what are the results of skin prick test in chronic urticaria. He has seen a couple of house dust mite allergy patients who are on allergen immunotherapy who have shown urticaria. So he wants to know your experience with such patients, sir.
Okay. Skin prick test, for urticaria patients, I do skin prick tests only for those who have associated allergic rhinitis. Because it's only my personal experience. I find skin prick test is better for inhaled allergens, and the blood test is better for food allergens. But there are people who I think they get urticaria due to, when 5 years old double mattress has 5 million mites. So you cannot get rid of the mites anywhere in the world. So all over the world there are mites, and the mites come out at night. They crawl on our body, eat our skin flakes. So when they eat the skin flakes and then they go back into the mattress during the daytime, morning they go back to the mattress. So how much ever you vacuum the mattress, you only remove the top layer, all the fiber of the mattress, but you do not suck out the house dust mites. Okay, so we are allergic. We are in rhinitis. We are allergic to the mite particles in mite feces and urine. But it's my theory that there are quite a few urticaria patients actually get urticaria when the mite bite them, because the skin is more sensitive, and the mite bite them. So there are some of my patients with severe allergic rhinitis who I use both sublingual immunotherapy and I use subcutaneous immunotherapy. So I find that those patients with severe urticaria associated with house dust mites, in addition to the urticaria, the allergic rhinitis improving, the urticaria also improves. So it has to do probably something with the mites biting, but that it's more physical methods would be more useful for those patients who are trying to avoid dust mites. what I tend to ask the patients to do is lie down, mop the floor just with hot water. After it dries, use a yoga mat and sleep on the floor. The olden days technique. Yeah, dust mite is a problem of effluence. Okay, if you lie down on a mat, usually you're not exposed to so much of dust mites. I don't know whether that answers your question.
No, sir, it does. It absolutely does. So we're getting a lot of requests to actually unmute them so that they can directly ask you questions. But again, we are in short of time, so I've made sure they can approach us anytime. We will finish off with one last question. There is a question regarding, does rice bran oil is commercially available? Is it commercially available in market, either in India or anywhere else? That is actually a question of one of the students.
Rice bran oil is commercially available in all the rice growing countries. The maximum oil is produced in Thailand. India has a lot of rice bran oil, which is in theory is a very good antioxidant and supposed to help atopic dermatitis. But unfortunately, what happens is it has, although they say it's natural, what we have tested here, when we have got bran oil that they've said is natural, and when we tested, it has 4% hexane. Hexane is used to extract the oil, and it prevents rancification. When the oil gets infected with the bacteria, it gets rancified very fast and you cannot use it. So hexane is the preservative. And when that, with that chemical, but those people who consume rice bran oil also usually would, until unless it's 100% natural, they will be consuming the hexane. But when applied to the skin, we have tried it on a few patients. It does cause some irritation, which I think is because of the hexane. Because in theory, the oil is supposed to be an excellent moisturizer, but the hexane, I think, causes irritation. So I personally I've stopped using rice bran oil. I've stopped trying to use it. I do use virgin coconut oil, cold pressed virgin coconut oil. That is definitely effective on the skin. But by mind, some people do get allergies to it because there's a protein. Any protein can cause allergy. There are 1 or 2 patients who I've used virgin coconut oil, and they've actually the eczema did get worse. But but by and far, virgin coconut oil is also quite effective on the skin.
Right. Thank you so much, sir. Again, we are very, 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 very thankful to you to have introduced to us to this new concept, which I'm sure no one has explored in India yet. And we would really look forward to take this concept forward in our center and amongst our allergy practitioners too. Thank you once again, sir, for being part of this oration lecture, the second oration of Professor Major.K.Nagaraju.
Thank you very much for having me.
Thank you, sir. Thank you so much. I now request Dr. Karthik to introduce our next speaker for the next session.
Okay, so after one session on atopic dermatitis and chronic urticaria discussion from the speaker, so we now move on to the next session, and it is my honor to introduce the next speaker, Dr.Dhanesh. Sir is a good friend and a colleague of mine. We were part of the first batch of fellowship in allergy and clinical immunology from Savita University. Sir is a consultant pediatrician allergy specialist in Goa, and he is part of the Medical Advisory Council of National Medical Council of India. He's the current president of IAP, Indian Academy of Paediatrics, Goa State, vice president of Goa Medical Council, and IAP national trainer in multiple forums such as the Under 5 Wheezing platform, childhood asthma, and allergy blindness and comorbidities. So I would like to welcome you to give your next speech.
Thanks, Dr. Karthik. I was a vice president of the Medical Council till recently, so my tenure of 10 years is over now. Thanks, Karthik. It's honor to deliver a guest lecture on this auspicious day for us, which was our mentor's birthday, and we will celebrate it every year with some other form of CME and taking our mentor's dream to greater extent, fulfilling his dream, and our country also will get a best of allergies and best of allergy practice in time to come. with that, I'll come to the today's topic. The lab diagnosis of allergic diseases. This top part can go. Just hold on. So I'll take about 20 minutes or 25 minutes for covering this and giving you this answer. Hopefully, I will succeed in giving this answer when the blood test diagnose this, and only blood test will be we know to know, but those who don't know, at least something will be there at the end of the lecture. Okay, there are a lot of tests like this in the market, in newspaper comes, and this lecture is being delivered for everyone, those who are not in allergy practice at the higher level, and those who are also. So for those who are not, they all go through all this, whatever available in the market. Some are okay, some are not. Something like this is all nothing and only waste of money, as they are not the right things to be tested. Where the role of the so-called panel come, we will also discuss. And there are a lot of market is flooded nowadays with this IgG test. This is nothing for, and they market, but even for intolerance, IgG is not an answer. Intolerance is not an allergic disease, and it's not an IgG mediator. Diagnosis for them is basically by eliminate very different, not like an immediate any reaction coming up with the food, but non-specific food reactions. So this is also coming up, and then many conditions like chronic urticaria. Everybody just feels it's just an allergic disease, but it's a massive. Some acute urticaria may have sometimes, even angioedema is acute, it's coming up within the ingestion of some specific food, then only it has a relation to IgG-mediated allergy. Otherwise, maybe you're dealing with a rare case of hereditary angioedema, or sometimes even this urticaria may be because of pressure in the school children, because of the bad pressure urticaria, and only removing the pressure can improve it. So this is the whole spectrum of allergics, allergy, and we need to answer how to investigate about this. And the answer is basically by clinical and rare tests. So clinical history is more important. And specifically, if you're dealing with a typical allergy march, in your history, if you go in back, and there is an eczema, family history of allergy, eczema, then comes wheezing in children, then allergic rhinitis, or wheezing has gone for some time, and then again it comes up later on in the childhood group or in the adulthood, allergic rhinitis coming up. Surely you're dealing with IgG-mediated allergy and need an intervention. And that's exactly has been imposed by all the agencies all over the world, and we should do. The early detection is important, and it's been recommended to know what is the allergy. So the diagnostic pyramid, that what we have to do is our base is history. History, and examination. This takes sometimes up to 1 hour for evaluate the patient, and very few tests that we know. And the most important of, I will go the skin prick test and the specific IgE test. And the final diagnosis is actually by the challenge test. And challenge test is not that easy, that you just give that offending antigen and you elicit the symptoms, but you may land up that patient with a severe anaphylaxis, and if not treated, you may lose also. So it's not that easy. So we just go. So those who don't know, so what is an answer? Everyone feels the eosinophobia. For the lower down people, there is it's increased, but there are many other causes. It's increasing in allergy. What about a total IgE? Is it a marker? Total IgE also is increased in allergic condition, in most of the allergic condition. But if you're very high, you may be dealing with so many other conditions. So what is the answer? Skin prick test for those who know allergy and those who are trained allergy. So there are very few in India. We may be about few hundreds in India those who know about it properly. And those who just know, do not know what they are doing and how to interpret it. So better know it. So those who are interested in it. And what you are eliciting here, because you should know what is skin prick test or what is specific IgE. In skin prick test, you are eliciting the antigen-antibody reaction. When antibody is sitting on a mast cell, and when antigen comes, antigen-antibody reaction takes place, and mast cell breaks out, and you get the same reaction in a smaller amount, very minute amount, you can detect on the whole aspect of the arm or on the back. But in serum-specific IgE, you are not eliciting this reaction, but only the floating IgE antibodies. So the efficacy of this test is very high, but even both the tests are not diagnostic. Final diagnosis is based on clinical scenario and not just because they are positive, whether it is skin prick test or serum-specific IgE. There are issues with skin prick test. We don't have a good antigen. Most of the lab doesn't have a good antigen. Most of the people, very few is accessible to the highly standardized antigens. And serum-specific IgE, there are very highly specific antigens available, but the cost factor also makes the problem and which one to test. So you should know something. So, but why in vitro testing? In vitro testing, blood testing, there are many causes. But today I will just think about only this last part, that doctors not trained in skin prick test. So whether they can get the answer which I have asked in the first slide, initial slide. So by now, you must have understood that it is not total IgE, but serum-specific IgE of that particular antigen which is more useful. And how to do it? There are about 3 machines all over the world, but among the 3, ImmunoCap is the gold standard, and fortunately, it is available in India. And you have to ask, when you are asking for your antigen, specifically serum-specific IgE by ImmunoCap method only. Otherwise, there are labs which have been flooded with all the wrong tests, ELISA tests, and so many other tests, and they will be nothing but just a waste of money. If at all you want to ask by serum-specific IgE by ImmunoCap method only. And again, there are another confusing things, because what the lab and actual positivity is just a 0.35 unit. So where 0.35 is also positive, and sometimes you get a reading of as high as 100 and above. So on this S-shaped curve, where it lies. So these are also an arbitrary thing, not exactly the grading done by any standard agencies and all. But if you are dealing with any antigen which is more than 100, specifically it's very high and very likely to be caused. If you are in double figure, about 10 and all, also it cannot be neglected. And even if you are in single figure, but if it is below 1, be careful, you may not be dealing. And there were many in a report, there may be 1 or 2 in 50s or 60s or above 100, like dust mite. And there are so many other fruits and all coming out about 0.4, 0.8, 0.7, and they may not be clinically relevant. Again, the clinical correlation is required here. So just the report may not be the answer, but maybe just be the beginning for those who do not know the allergy. Then you can refer it to those persons who know it and get the better answer. And don't do the final answer and start telling them to avoid this, that. They will only go in malnutrition. So which allergens you are going to put? In India, dust mite is the most important in allergens. About 60 to 90% is only dust mite, house dust mite. And you have to ask for all 3 dust mite. T. perinate, terinosis, and blomia also. So blomia of earlier, now of late, most of the lab are using it. And hopefully lab gives only these 3 groups. And that's really enough. We'll tell you about your 90% allergy if you're in the coastal areas where the humidity is very high, and other places also up to about 60 to 80 and all. And specifically in children, we are dealing with the children in the pediatric age group, below 5 years and all. It is the most important allergy. They are not sensitive to pollen and other important virate type. Very, very few food like milk and all. And where the dust mite we get, everybody, I'm not going in detail about this, but these are the places. So wherever there is upholstery, humidity, high humidity, these are very, very rampant in every house. The other antigen important is a fungus, which is there again wherever there is a moisture. Everybody's bathroom is full of this, and they are in the outdoor nearby area also. The few allergenic pollens in most of the cases in India, it's a grass pollen, and Cynodon dactyline is the most important grass pollen. The other one, a few weeds like amaranthus and parthenium, and somewhere the brassica, wherever it is there, and very few tree pollens. It depends on area specific. Like halophilia is a major problem in Rajasthan Rajasthan, Jaipur area, and some of the northern India, like acacia and prosopis and other things comes out. So animal dental also is there, but everybody comes and asks for to do the test for animal, especially cat and dog. If they have a pet, many times it's not fine, but you have to have a clinical correlation, but this be included. So if you want to include some group of antigens, which you are going to include. So if your child is a small, below school going age group, then include the indoor antigens and outdoor antigens like pollens. If the child is going out and which pollen to use, it depends on your region specific and season also. So that your allergies in your area will tell you which one it is. And it differs. It differs in Delhi, it differs in Chennai, it will be separate in Kolkata or in Pune or Srinagar. Srinagar and all, it's all like a English, whatever, like in European antigens. So serum specific IG, this is some small rough chart which I had given for below 5 years and those who are above 5 years. Those who do not understand this, then they rely on company. So company has done it. Hopefully company also stabilizes it with a regional wise, all their panels and all, help those who do not know it properly. And the food, which food to test, even this and that food everybody tests. But these are the 8 foods which are very common. And the other addition to that one in India is our dal, chickpea and other lentils and all. And peanuts are less common than the dal and all. So whichever and most important allergen in small age group is milk, and it passes off in most of the cases. So if you get a serum specific IgE for food, is there any correlation that maybe you have a very high positive predictive value or sensitivity specificity high? There is no definite clear-cut guidelines on this, but most of the literature reproduce this particular study by Samson HA, and it's more realistic. There are some figures given there, like if it's more than 15 of milk, the positive predictive value is very high, 95%. Same if less than 2 years, the figures are given down. So is it a diagnostic? Serum specific IgE is not definitely diagnostic in food allergy. It's a skin prick test also can be done. And this is the indirect method. Direct method is oral food challenge. And I told you it's not that easy as to say because you may get a severe reaction. So is there any answer? Basophil activation test is something like doing challenge in a test tube, but not as easy as is drawn on this slide that you remove the blood and put in a test tube. It's a very difficult thing, always available nowadays. Only in the research setup, you have to remove the blood and imagine it, and that's not that easy. Hopefully, the way the things goes up nowadays, all the technology come up. In future, if we get it, it will be the best scenario for us to diagnose food allergy easily. So there are roles for a specific IgE to repeat because there is always a newer sensitization is the most important thing. So somebody is sensitized to pollen in very early group in the childhood. They may develop to pollen 1 pollen, 2 pollen, 3 pollen, and this is the reason why you may have to repeat it again afterwards if the patient is not improving, and also a reason why you have to do intervention like immunotherapy, because if you halt it somewhere here, then the further thing doesn't go up. So I'll just, before handing one slide on drug allergy, because everybody feels that there are a lot of drug allergy tests also available in the market. So very few of them, it's not a shortcut, and very few of them are validated, like penicillin, cephalosporin, and others. But here also the answer is not 100% because negative tests do not rule out drug allergy, and positive is not confirmatory because we do not have ideal antigens available for the testing there. The recommendation is not to be used as a single step without skin prick test with non-irritant preparations. Now, these non-irritant preparations are not available, and then the allergists do this provocation test. So even for a test dose, what we are giving, like even for cephalosporins and all, it is not a non-irritant preparation. So like your ceftriaxone and all, non-irritant preparation is not the one which just that. So be careful, especially when you're delabeling the patient with a drug allergy. And if you are having sometimes again and again somebody getting reaction, serum type test may be helpful. So you do it immediate sample within 2 to 8 hours. level goes up after 2 hours, speaks about in a few hours, and then comes out after 12 hours. The 2 samples are required afterwards also. So these you can keep up and then discuss with the allergists. So where does the Paediatrics test lie, which is again another common? What has been done in the Paediatrics infant and adult is that the common allergens has been mixed by the companies, and you get it positive or negative. It's a rough scenario for those who do not know anything, but it's not a clear-cut answer for the screening test. Only the where if you are dealing with something about allergy, then this whichever antigen, like most important dust mite will be always there, and there are some other antigens. So that's the reason 80% dust mite is positive. That's the reason it comes positive, and then you need. So you can do it. Those who don't know, and then can send to the allergies or other further tests with the help of those who are allergists in your region. You can solve your answer. So before I'm ending, I'll just go about this new thing that we are all testing about the crude antigens. So can you test the molecular level of antigens and can give the better answer? Because this one particular tree pollen, birch pollen, they have a cross reactivity with so many fruits. So if you have a molecular level of antigen, then you can diagnose exactly there is a cross reactivity or not. More than birch pollen, we have our problem with the dust mite. So those who are into allergy practice, if we get a CRD only of the dust mite, whether about 23 components and only DRP1, DRP2 or DRF1, DRF2 is more important, then you know that which immunotherapy to be given. And if it's a tropomycin type of thing is positive, then it's not required. So these are the answers you will get. Even there are a lot of time cockroach and other shellfish comes positive, and everybody thinks they have to avoid it or get rid of this. So some people are giving cockroach immunotherapy also. It is not at all required. So this will give answer. And there are some specific components which are the markers of severe reactions. So some of them I've just listed in this slide. We are not dealing with the CRD in detail. Something like omega-5 gliadin, for example, if you just do, if somebody is having a wheat-induced, exercise-induced, wheat-derived exercise-induced anaphylaxis, which patients sometimes take that particular food, usually the feed, and after exercise, you break out into anaphylaxis. If there is a clear-cut history here, you just do omega-5 gliadin, one test, and could be positive. And other tests are required for it. So for plant proteins, there are something called as CCDs, to storage protein. So if the storage protein type of antigens are positive, is a very high risk. Then comes the LTPs, and lower down is just a cross reactivity. So you should know about this, which are the stable proteins, which will induce severe reaction. So everything, and then only you will come to it. It's a breaking head when you're this new thing has just entered the Indian market, and we may get a better one. And at the moment, whatever we are having is a mixed one with 100 or 200 tests available. And if we get a specific antigen coming in this, we will get an answer, because if you get milk only, just do the milk antigen. And if you have something like BOSD, 8 casein positive, you know that you are dealing with a severe reaction with the milk, and it might not go off easily. So, similarly, with the egg, CALD1 is an important antigen. With peanuts, there are these major storage antigen with a severe reaction. If you know that it is not a tropomycin which will come positive with a dust mite, but other major important, that's important if you have a specific. So if we get what is available at the moment is something like this exact, which is hundreds of antigens, but in time to come, if we get a specific antigen, single antigen, so some specific antigen, it will be better for us. So this answer that why our allergy will go away, or with not only allergic rhinitis, we should get an answer. And if you don't know how to investigate for allergy, the thorough clinical history, and then very specific tests. If you don't know serum skin peg test, then serum specific IgE in a whichever required manner, and very few for molecular allergy testing, which at the moment confuses more when they give diagnosis. And hopefully, if you analyze everything, if you analyze all whatever is available, then we can get an answer. We can give the patients an allergy immuno-free immunotherapy and free life. Thank you very much.
Thank you so much, dearest Dhanesh sir. It was really a brush up for all the practicing allergists and definitely an eye-opener for all the new budding allergists who want to know about what is there in allergy diagnosis when we are not fluent with the skin test as such. We have a couple of questions if you have time to take, sir. One of the questions is actually a participant has asked your experience with component dissolved diagnosis.
What? Component? See, my experience, this is just come recently. And my experience is we need, but we don't need the multiplex, whatever we are having hundreds of antigens and creates more confusion. And it should not be done as a first line and directly by lower down doctor. Only if we are having a whatever confusion status by allergies, they have to do it to rule out it. Unfortunately, when we are doing it with a few cases, we get a good answer and whatever the problem is there. But there are a lot of things come positive and we have to look after why this is there. Really it is there or not. And some things which have come positive are not at all there in our country. So it's a confusion status initially, but the learning curve for us, but definitely we get an answer. Like immunotherapy, if we start, I told you that dust-mite, which one to put, how much to put, that answer is there. And very rarely, sometimes all this other allergy also we can get.
Thank you so much, sir. We have another question by a doctor who was wondering if these tests, especially the specific IgEs or the blood test as such, can predict the antihistamine dosage or steroid response as such.
IgE test? No, it doesn't. Yeah. It just tell you that whether specific IgE is there in that much amount in the blood or not. Yeah. Yeah.
Another last question, since you have touched upon the drug allergies and measuring drug allergies as such, we have a question by a doctor. How accurate are the blood testing in case of drug allergies?
No, it's not at all accurate because the line of testing, the recommended guidelines is totally different. It's not by blood testing. It's by the skin prick test or drug provocation test or intradermal test afterwards. That's all you have to do ideally. These are all indirect evidences and not very highly rated.
Thank you so much, sir. One last question regarding food allergies. What exactly are the panels that you suggest for screening kids whom we suspect food allergies who are less than 2 years old or less than 5 years old?
There is no direct answer for this because everything we need a history. So it depends on your history only. So but most important allergen in a very small group of this age group of small age group is a cow's milk, and there will be peculiar history that patient is not on breastfeed. There may be a history of allergy in the family, atopic dermatitis come up, and then they have a non-specific symptoms also, like pain in abdomen, there's the other thing, diarrhea and all. They may be non-IgE mediated also. So even if the specific IgE of milk comes negative, you have to only give an avoidance for about 15 days and then reintroduction and see if the symptoms come up again. So that's an answer. If the clear-cut milk allergy is there, they will get a reaction. Immediately after consuming milk, other than the breast milk usually, they will get a reaction. They will get a rash. They will start getting cough within 2 hours. So then you are dealing with that particular food antigen. So similarly, when you are weaning, and that time also, if you get with any of the such a symptom which is coming up within about 2 hours, then there is need to ask for that particular thing. So panel as such will not give you, but it depends on which one. So if you still want to go, you can do milk, and you can do the whichever simple food allergy which I have told you if they're having a doubt, and then discuss with the person who knows the allergy in your area, and then take the answer and don't make the patient malnourished. That will be better.
So we have a question from one of our doctors in Nepal. So their question is, in the current scenario where they don't have access to standardized antigens for skin prick test, how much can they rely on the specific IgE testing?
See, if you don't have a very highly standardized antigen, whatever antigen available in India also, we cannot call them, they are not at all standardized. Unfortunately, they cannot standardize to the highest level. There are many issues today. So if you do not have an access to a higher level, you do the skin prick test with whatever antigen you have, if you know the skin prick test, and you can correlate it with your serum specific IgE also. So you may get a better answer if both the things are there and based on a clinical background. So if there's a clinical scenario correlating with everything, you can get an answer. If you are a new person, with slowly with your experience, you will come to know it if you are in the allergy practice.
That would be the last question. Thank you so much, Dr. Dhanesh sir, for giving us this opportunity, taking part of this wonderful session also. This would actually conclude the session for today, the online session for today. On behalf of the team of Prof.Major.K.Nagaraju Academy and all the alumnus of sir, I would like to take this opportunity to thank every one of you, especially Professor Sellappan sir and Dr. Dhanesh sir. Before I just conclude my speech, I would also like to thank Thermo Fisher, the team of Thermo Fisher. I actually invite the team of Thermo Fisher to share a few words. Thank you, ma'am.
Good morning to everyone present here. I'm Shubha Nayak from Thermo Fisher. And today, on behalf of Thermo Fisher Scientific, I'm quite obliged to have got this opportunity to say a few words of gratitude for Professor Dr. K. Nagaraju. So Dr. Nagaraju sir has contributed immensely in the field of allergy, and we are very proud, to call him as the father of pediatric allergy. And especially standing here on behalf of Thermo Fisher, when we talk about sir or we think about him, past few years he has supported us immensely, and his contribution for creating the market awareness, especially for ImmunoCAP, has been really remarkable. And he was always very passionate in promoting ImmunoCAP, and he's always spoke a lot about Padia as a whole. And it is because of this passion, I truly believe that we are here with you all together at this forum, where we talk about allergy, and we are trying to create a lot of awareness and give a solution to the patients who are suffering from allergy. I would like to call upon Dulabai, who's our head, to present the organization of Dr. Nagaraju sir. Please join us here.